2 Shiba Inus, and one of them passed away unexpectedly on Tuesday night late. She was 14. And my doggies are my kids, and so I have kind of the fog of grief about me. So if I'm like, say something that's gibberish or blah, just say, and just have me. So I'm a little bad. So again, bear with me here as we move forward. So talking about breastfeeding, how many folks yesterday, there we go, yesterday's, their moms breastfed? Okay, whose moms did not breastfeed yesterday? Really? One, okay. And tell me a little bit more about that. Kate, do you know, was it something she didn't want to do, or?
Yeah, she was supposed to have delivering, she was just really exhausted.
Okay,
And was okay with supplement formula.
gotcha. Has anybody had somebody doing both, breast and bottle together? That's a pretty common thing as well. And so I think it depends on which camp you're in. There's a lot of emotions tied to breastfeeding, as evidenced by the lady who got really upset at Texas Roadhouse and is now suing Texas Roadhouse because she was told to put a napkin over her baby, and that whole situation could have been handled so much differently. And I think the other thing is, if you're not from this area, you don't realize there's actually been several incidents related to breastfeeding in public in Kentucky. And so there's a lot of stigma with breastfeeding. Some people are very strongly for it, and some people are opposed to it. They feel like it's private. You hear the arguments like, well, just look away, and that sort of thing. So I think there's a lot of issues related to breastfeeding. But from the Texas Roadhouse story, again, there was information shared about that it is legal to breastfeed your baby in public. So when last we left, we were talking about breastfeeding rates. And so again, looking here at Kentucky, you can see babies that were ever breastfed, 66%, Mississippi, 52%, very low. So some of that has to do with race. We actually see fewer African American women breastfeed than Caucasian women. Some of it has to do with role modeling. So in talking with older female relatives, and sometimes older female relatives discourage women from breastfeeding. In Hispanic population, some Hispanics believe that the colostrum is contaminated, and they don't want the baby to have the colostrum. They want to wait to breastfeed until the milk comes in. So a lot of times what we'll do with patients who kind of refuse to nurse initially, remember, if she doesn't nurse, we're not going to get milk production occurring. What we'll often do with those patients is encourage them to pump at least every 2 to 3 hours, so that starts kind of this hormone response, so that will help the milk come in. In some of our patients, we can do education and encourage them to go ahead and give colostrum. In some cases, they will give the colostrum in a bottle rather than through the breast. Any colostrum is better than no colostrum. But again, there's a lot of variations when it comes to when people breastfeed, how often they breastfeed, and how long they continue it. So I'm looking at, milk production, how you create milk. There's two things that need to work together. So you have milk production and you have milk ejection. So prolactin, remember that prolactin is a hormone that actually elevates in pregnancy, and it stays elevated if you continue to lactate after delivery. If you choose not to lactate after delivery, your prolactin levels will decline, okay? So that comes from the anterior pituitary gland. Prolactin has an A in it, so that's how I remember anterior pituitary gland. Remember that milk is produced in the alveoli and it's stored in the ducts. So between feeding, so after feeding, the breasts will feel softer. As we get closer to time for feeding, they're going to feel more full. That's a good sign, okay? It's not the best sign that breastfeeding is effective. I'll say that one more time, okay? So in other words, I nurse the baby and my breast feels softer and less full after I nurse. And then 3 hours later, my breasts feel heavier, and so I'm making milk. That does not necessarily mean, that's a good sign, but it's not the best sign that you have an effective breastfeeding. Usually when it comes to effective breastfeeding, we're looking at indicators from the baby. So things like weight, peeing and pooping, things of that nature. So milk ejection, for some women, this is kind of an overdrive. Some women, their letdown reflex can be so strong that they literally like spurt milk when they have the letdown reflex. There are different things that cause the release of endogenous oxytocin that cause the letdown reflex to occur. But with this, this is again what causes a contraction, and you need this stimulation to help with the letdown reflex. So it's not just tactile, it's not just putting the baby on the breast and kind of assuming that the milk will let down from the breast, but you also want mom to be very relaxed. She needs to be well rested. Usually she's staring at her baby, she's comforted by her baby. So that sounds great, right? Everything should work great. Well, you don't get that same emotional response with a pump. Some women feel really, I don't know, they're not emotionally attached to their breast pump. It's very kind of matter of fact, I have to do it. I only have a 15-minute break, so I'm gonna pump. So sometimes women struggle with that, with their milk letdown reflex when they're having to pump. Or NICU moms are another great example who sometimes struggle with that. So anything we can do to kind of get them emotionally and kind of have sensory input to help with that hormone release will be helpful. It might be looking at a picture of the baby, being nearby the baby. Maybe the baby can't nurse, but at least I'm nearby my baby and can kind of thinking about my baby as I'm pumping at the same time, okay? And that's one of the reasons why we really don't want people pumping in the public restrooms and places that aren't really sanitary and safe, and it just doesn't set women up for effective breastfeeding. So in looking at the stages of human milk, so you can kind of see where if we pumped, this shows you that liquid gold of colostrum. And so you could see where some folks might look at that and think it's curdled milk. It's thicker, it's richer, and it's in very small amounts. So you're not going to get ounces of colostrum when you pump. The other thing is, in general, most of the time, babies are much better at getting colostrum and milk out of the breast than a pump is. There are some exceptions. For example, premature babies, because they have a very weak suck, they're not able to pull milk out of the breast effectively. Babies who have a really short frenulum and they don't have that suck, swallow, coordinated reflex, they're gonna have problems with breastfeeding. So that might be a mom who will need to pump. In this colostrum, this is present the first few days. Again, it's gonna give some of that immunoglobulin to help the baby fight infection. So this is also why whenever I have a mom who has a sick baby, let's say everything was fine, but now the baby's in the NICU because the baby's has low temperature or high temperature, or we're concerned about infection, I would encourage mom, if she can't nurse, to pump that colostrum, and we'll give the colostrum to the baby. So let's say mom delivers at 27 weeks, okay? Can she still make colostrum? Absolutely, okay? So we still will have her pump. The baby's too little and too small to be able to latch to the breast, but absolutely we want to give that little 27-week or any colostrum that mom is able to pump out. When you take colostrum, there's no supplementation needed, and the other big plus for colostrum is that it has a laxative effect, so it's going to help you pass the baby past meconium, so we're going to see less risk of jaundice with babies who get colostrum. With transitional milk, this happens around day 3 or so. You see a big change in quantity produced. So again, kind of looking back here, you can kind of see the difference. Again, often less than a half an ounce. Again, may just be a couple tablespoons of colostrum. And then this transitional milk, maybe an ounce, might even be a little bit less than that initially with a pump. Now again, remember, babies are better at getting more milk out of the breast. Some women are the opposite. Some women are great milk producers, and they produce a lot of milk. But with this transitional milk, it's more watery. It's very high in fat, lactose, and vitamins. And so what that does a lot of times is it satiates baby's hunger. So I don't know if you've heard anybody talk to your moms about, don't have the baby use you as a pacifier. When we talk about breastfeeding, we actually want the baby to latch on as kind of much as they can. Some babies will cluster feed, so it's like you nurse, and then an hour later you nurse again, and an hour later you nurse again, but then they have a little break in between. The big thing you have to be mindful of is the more the baby nurses, the sooner this transition will occur. Whereas if mom had a C-section, she didn't nurse a lot in the hospital, then this will delay the production of that transitional milk. So this is one of the key kind of points in terms of successful breastfeeding. If we can get her to day 3, often what happens when the milk comes in on day 3, her temperature might go up slightly, and then we're watching really carefully for engorgement. We don't typically see engorgement with colostrum because the quantity's not there. But around day 3, so again, we're watching for engorgement, very painful, full breasts. They tend to be bilaterally. Now, mature milk comes in after about 2 weeks, and I call mature milk kind of like skim milk. It has kind of a bluer tinge. It almost looks kind of watery, and I think because people are so used to seeing formula in bottles that they think it's less than formula. It's not. It is, again, everything the baby needs. It is perfect for baby. And when we pump milk, in, let's say you have a mom who's not nursing, who wants to have the baby get breast milk through a bottle. You have fore milk and you have hind milk, and so that's, again, kind of showing you the difference there a little bit. Fore milk is the very front milk, the very first milk that the baby gets in the breast. It's more watery. It alleviates thirst. Versus hind milk is the kind of the back end of that from the breast. It is higher in fat. So if you are a nurse working with a mom, whether you're a peds nurse, OB nurse, whatever, if you're working with a mom and she's struggling with breastfeeding, one of the key things is that, is the baby getting both fore milk and hind milk? So they need the baby to stay latched on and nurse long enough. So if you switch too quickly, in other words, you might be going from right to left, right to left, right to left, all you're getting is fore milk, you're not getting hind milk, which helps the baby gain weight. My experience with women with breastfeeding, a lot of times the baby is not emptying the breast completely, and a lot of it has to do with positioning. People tend to kind of nurse in the positions they see on TV and things, and so if we just change them to like a football hold or sideline, it's amazing what just even gravity kind of, again, where they can kind of lean over, but a lot of it is psychological of having them relax. A lot of it has to do with sleep, rest, and nutrition. Women who are severely restricting calories, they're not going to make milk. So here's benefits for breastfeeding. Obviously, both for mom and baby. With the baby, we see less risk of some chronic conditions. That includes asthma, gastroenteritis, necrotizing enterocolitis. That's called NEC. We see that a lot in premature babies. That's actually where a section of the gut dies off. And it, again, can be deadly. Notice again the decreased risk of SIDS, obesity, childhood leukemia. So again, great for baby. We're much less likely to see childhood obesity in a baby that was breastfed. We see that more in formula-fed babies. The other thing is some of the babies who are solely breastfed, again, they will often have a little bit leaner look to them, and that's, again, kind of normal. But for us, we're used to those fat little chubby babies, and it's all these folks who kind of overfed their babies. With mom, we see the big thing is postpartum bleeding. That's obviously the big thing for us initially, because we want to stop that risk of postpartum hemorrhage. But long term, you have a decreased risk of ovarian cancer, breast cancers, type 2 diabetes. So let's say mom is gestational diabetic. We would say, you know what, let's breastfeed, okay? Breastfeeding expends energy. It actually will keep your sugar under control. We would not restrict you from breastfeeding because you're diabetic or on insulin, okay? It saves a lot of money, it's easy, it's convenient. I think the big thing is that people think you should naturally be able to do it. And not only do you kind of have to learn and adjust, but your baby also has to learn and adjust. And sometimes you get it initially in the hospital, but then later you have problems. And so that's why there's a big push for lactation consultants and further breastfeeding support beyond 3 days at the hospital. So what are some limitations for breastfeeding? These would be reasons why people are concerned, or what's different about breastfeeding compared to formula feeding. Babies, when they breastfeed, they're going to need to feed more frequently. Formula, it takes longer to digest. So a breastfed baby might eat every 2 or 3 hours, whereas a formula-fed baby might go 3 or 4 hours. Again, for some women, they feel very private, and so they don't want to expose themselves. They want to have their partner involved in feeding, and they feel like breastfeeding will exclude their partner from being participatory in the process. Some women have pain, and I think that's another thing that some women didn't realize. No one ever told them that it could be painful, and some of it is pain on the nipple, some of it is pain with cramping, because whenever you nurse, you have the release of oxytocin, and it causes the uterus to contract, which is going to cause cramping. So I think that's another key teaching element. For some women, because of the hormone fluctuations with breastfeeding, this is a term for painful intercourse. So we see a lot of vaginal dryness. So women who want to resume sexual activity, they're probably going to need some type of lubricant. We usually don't recommend sexual activity until after about 6 weeks postpartum. And the reason for that is just to kind of minimize the risk of infection. You kind of want to let everything heal and kind of return back as close as possible to that pre-pregnancy state. Now that said, a lot of women do engage in sexual activity before 6-week checkup, and I would say, believe it or not, less than 50% of women actually go to their 6-week checkup because they feel like I'm healthy, I'm busy, I got a baby to take care of, I don't have time to go to the doctor to get everything assessed. It's a huge issue because we have to have a big talk about contraception, and it's also an opportunity for us to check and see how breastfeeding is going. So we really want to encourage women to go to that 6-week postpartum checkup. Some moms may need to monitor their food intake. Sometimes what you eat affects how your baby tolerates it. So if you like a lot of spicy foods, when you pump, you'll actually see the color of your milk change based off what food you're eating, and you'll find that baby doesn't tolerate it very well. I know I had a lactation consultant that told one of our moms once that she was a big milk drinker and the baby was really gassy, and so she advised the mom to decrease the amount of milk that she was drinking to see if that would decrease the baby's GI upset. And then this limitation of contraception options, what I would put in parentheses there is we're really talking about the pill, and that's because that's the most common contraceptive method that women use is the pill. There are a lot of other options that you can have while you're breastfeeding. There is a pill called the mini pill. I don't know, has anybody heard about the mini pill or had your patient get prescribed that? With that, it just has progestin only. It doesn't have that estrogen with it. And the reason they give that mini pill to breastfeeding moms is they don't want to do anything that would impair milk production. But let's say you have a woman who wants to get back on the pill and she's breastfeeding. Can she take the pill while she's breastfeeding? Absolutely. It's just that they usually want you to wait until your milk supply is well established. And so that has to be kind of after that 2-week mark. So again, you have somebody who's 6 weeks postpartum, she's breastfeeding well, the baby's doing fine. If she wanted to get started on the pill, most OBs would go ahead and have her start taking the pill then. Okay? But we don't generally have people start taking the pill right after delivery because it can mess up milk production. So let's talk a little bit about contraindications to breastfeeding. So these would be things that, again, we would not want moms to breastfeed. There's not very many. I would say the big one here for us is maternal use of street drugs or chemotherapy agents. We do have women who are diagnosed with cancer during pregnancy, or they're diagnosed with cancer immediately after delivery. So if they're getting some type of toxic medication that can be excreted in the breast milk, that makes sense. We don't want to have baby get that. The other one is for us is HIV, and there's actually a push for us to reconsider what we're doing with HIV positive patients. So in the United States, we had been, if you were HIV positive, saying no breastfeeding. Well, in other parts of the world, you're HIV positive, there's no other access to any other nutrition, so you're gonna feed your baby. You can transmit HIV through breast milk, but what they have now found is if we can keep the viral load very, very low or undetectable, then you don't transmit. So that's a great option now to think about in terms of these HIV positive women could breastfeed their baby. I haven't seen it around here. There's still kind of a conservative approach, I think, concerning that, but I would not be surprised to see that change. True galactosemia, which is rare, it's a congenital metabolic defect or disease. And so one of the ways that we would know the baby has that is through the newborn screen. So So the newborn screen is that test that's done with a heel stick and the 5 little dots. And it's done after 48 to 72 hours after the first protein feed. And then that goes off to the State Board of Health. Like, we don't get the results, but it gets reported to the pediatrician. So there's all different kinds of diseases that are screened for on that test. It's not just metabolic diseases like galactosemia, but it can include things like sickle cell, cystic fibrosis, maple syrup urine disease, all kinds of things. They keep expanding what they screen on that newborn screen. It's also known as the Guthrie test. I've never heard it called that. I've always heard it called the newborn screen. Is there any other thing that you've seen at clinical? Do you guys know what I'm talking about? A lot of times we don't get the test. You might have like lab or nursery, or they kind of have a designated time when people come and get them. But it's usually one of those things that we want to make sure we get before the baby's discharged. So, active TB, radioactivity. So if you had an implant, which again I have not seen, active herpes lesion on the breast, and then again depending on what medications the patient's being treated with. Sometimes patients have chronic health conditions and they have to be on certain medications that are contraindicated with lactation. So with lactation consultants, they carry these big giant resources, or they carry a great resource on their iPad or their phone, and they're constantly looking up medications to see whether or not they can be used with breastfeeding. So let's say a patient has epilepsy and she needs to return to taking her medication to control her epilepsy. What the lactation consultant might do is to work with the neurologist and say, hey, could we switch her to this other medication while she's lactating, keep the epilepsy under control, and it's not contraindicated with lactation. So these are the American Academy recommended practices with breastfeeding, that babies should be fed on demand. So babies are not being selfish, they're not trying to get attention when they're crying, okay? And so the idea is we really want to have babies eating at least every 3 to 4 hours. I would not have a baby go longer than 4 hours. Smaller babies sometimes have to eat more frequently. So if you have a baby that's term, but is maybe only 5 or 6 pounds, that baby would want to be more in the 2 to 3 hour schedule than the 3 to 4 hour schedule, if that makes sense. So smaller, more frequent feeds, especially if your baby is having a lot of reflux, it would be better for your baby to have smaller, more frequent feeds. Crying's a late sign. You got a crying baby and a crying mom and milk's leaking everywhere. It's just kind of a hot mess. So we don't want to, again, wait for that. Now, what we're seeing is that sometimes we have very complacent babies and they are sleepy babies. They do not want to wake up. So has anybody had to wake up a baby? Yes. What did you guys do?
I unwrapped her
Okay.
and like tried to just make her uncomfortable.
Oh, okay, yeah.
Just like position, like take out the swaddle.
Take her out of that kind of warm fetal position.
So yeah, I tried to just like kind of expand her, but she was really sleepy. I tried to do like the rude, like
Yeah,
just stimulate her. She
Okay.
was really preterm though.
Okay. Anybody else sleepy baby? Sleepy baby?
My sister's baby.
Sleepy?
I had to feed him before he got circumcision.
Yeah.
So we were just kind of messing with him, but he
Wouldn't wake up in that deep sleep mode. So sometimes, again, you're kind of fighting against Mother Nature. You know, it's like us, you know, bears in the winter. You know, I was just like, no thanks, I'm not getting up. So what I would suggest is we uncover them. I think another thing that you can do is take the diaper off, because sometimes cold air to the genitals will kind of wake them up. Cold wipe on the bottom. We'll rub their back or flick their feet. So Christina mentioned the rooting reflex, kind of trying to touch around the mouth to try and stimulate that. A lot of times I'll kind of take their cap off and stimulate their head, but sometimes, again, they just won't wake up. And so you're like, okay, that's fine, but then you'll just wait and then try again in about an hour or so. Because again, babies' sleep cycles, they're not like us, they're not gonna sleep 5 or 6 hours solid, and they should be waking up. So we want the baby to eat about 8 to 12 times every 24 hours. And when the baby nurses, we wanna have 10 to 15 minutes of active sucking or swallowing per breast per feed. And so that's another thing, is sometimes very sleepy babies, like, okay, I'll wake up, and then they go right back to sleep. So they're on the breast, but they're not really doing anything. I wouldn't count that as a feed. Okay. And then this is also something I would put a little highlight and a red pin on. With breastfeeding babies, we do recommend a vitamin D supplement, okay? We do not have to do that with formula because the formula already has the vitamin D supplement in it. And the reason for that, I think, again, is we're concerned about kind of long-term vitamin D storage, and vitamin D is fat soluble. I also think women are kind of more, they're not going outside as much anymore, and so I think that may be a role in how that helps with the metabolism of vitamin D and things, but that's, again, it's one of those things that's relatively new-ish, and so not a lot of people know about that. We do not supplement formula-fed babies. It's only breastfeeding babies. So if you're doing a combination of breast bottle, you probably don't need to supplement. You're probably getting that vitamin D through that extra formula. It kind of depends on how much formula the baby's taking. So I guess I would add the word for all, or breastfeeding only, whatever little adjective or word you want to put in there, so.
Are we supplementing the babies or the moms
The
taking
babies.
it?
You're supplementing the babies.
Yep.
In terms of breastfeeding intake, the baby is nursing at least 8 times in 24 hours. So again, if you're a schedule person, that means every 3 hours. Babies don't always like schedules. So that can be kind of distressing. So one of the things that I would tell a new mom or a parent is you sleep when the baby sleeps. So if the baby's sleeping from 10 to noon, that's not the time to do all the laundry, pick up the kids' toys, run to Target, get diapers, and come back. You need to sleep if the baby's sleeping from 10 to 12, because when you guys are up from 1 to 3 in the morning, you're gonna be really tired. And I think, again, that first 2 weeks, it's really optimal if mom can focus on taking care of herself and taking care of the baby. So trying to do kind of additional tasks. You have to realize for a lot of moms, though, they really wanna do those things because they wanna engage their other family members. And again, it's that super mom thing of, I can do everything. Yeah, but you just had a baby. You're not sick, but it's a transition, so we need to help support that transition. Make sure that when you're feeding the baby you can hear them swallow, and that happens more with transitional milk than colostrum. You're not gonna hear that gulp, gulp, gulp with colostrum. So we may not hear that in the hospital, but once they start going home and once we get to that transitional milk, you're gonna see more of that. The breasts soften after breastfeeding. This is the big one, wet diapers, and then stools change. So again, first day of life, we need to have at least 1 wet diaper, 1 dirty diaper. Second day of life, we should be seeing more wet diapers, at least 2 or more. Should see 1 stool or 2. Third day should be going, so again, you're increasing right around day 5 or so, then you're really going to town, okay? And so multiple wet diapers, multiple stools. Remember, when you're breastfeeding, it's easy to digest that, so that stool coming out is gonna look kind of runny. It's not gonna be clumpy. It's not like a adult bowel movement. It's frequent. So again, that's what babies do, is they eat, they sleep, they pee, they poop. They eat, they sleep, they pee, they poop. So what's the most effective means to evaluate? Quite honestly, one of the big things they look at is weight. And so that's another reason why with new babies, we usually want to see them in the pediatrician's office within 1 to 2 weeks after delivery. So that's another key visit, health promotion visit. We're not given vaccines, we're not getting shots at that visit, but we're trying to see how they're doing. And the other key thing with that visit is talking about safety issues. So for example, we want to make sure that mom is still putting the baby back to sleep. A 2-week-old cannot move its head to get out of that pocket of carbon dioxide. They're at high risk of SIDS. We want to make sure that, we're mindful that we don't leave babies unattended laying on the couch. We're asking about car seats. We're asking about, this kind of weather is really rough for new parents, because on one day your baby is freezing cold and you've got to put all this stuff on them. The next day it's 65 and it's like, okay, they don't need that really cute little winter coat that I got from the shower. It's just like us. So layers work really well with babies. But I have seen it over and over again where moms, parents, caregivers did not recognize that the baby needs clothing adjustment just like we do. So they kept either putting too much on the baby when it got warmer, or it got colder and they didn't think the baby needed more. So So I would say, again, when I think about this big list, I think of weight, but then after that, I would say urine and stool. Any questions on that? Does that agree with what you've been hearing at the hospital? I want you to feel really comfortable. If there's anything else, is there anything else that you've heard at the hospital from either the lactation consultant or the mother baby nurses about breastfeeding in terms of intake? Because this is a key teaching. This is one of the big stressors. And I think that's a lot of things that grandparents get concerned about, because you can't say, oh, the baby got 2 ounces. And I think another thing that I've noticed recently in moms is that moms will solely pump, so they'll never put the baby on the breast, and they pump their milk and then give the baby the milk through the bottle. So when somebody says they're breastfeeding, what you think is breastfeeding and what the patient's actually doing may not be exactly the same thing. Okay? All right. So taking care of breast milk, you want to make sure, just like any type of food product, good hand hygiene. It doesn't need to be in sterile containers, it just needs to be in clean containers. When you take a milk to child care, it needs to be labeled appropriately. It is considered a medication error. It's an incident report if a mom got the wrong milk, if the baby got the wrong milk at the hospital. So in other words, I can't give the breast milk from Julie Jones to Mary Jones's baby. So I go through those 2 identifiers just like I would with any medication. We always use the oldest milk first. In other words, you don't want to use the milk that just got pumped today. It's better to use the milk that got pumped a couple days ago. Use that one first. Don't add fresh milk to already frozen milk. Don't save milk from a used bottle. Again, germs in the baby's mouth can go back into the bottle and contaminate, so you get newborn illness and other infections. And then don't refreeze breast milk once it's been thawed. We do not recommend that you microwave breast milk either. Some women, they actually freeze it, and if you microwave it, it actually heats it unevenly. And then the other thing is it could destroy some of the good properties of breast milk. It's better if you put a microwave water, get water that's hot, and then take your container of breast milk and put it in the warm water. The warm water will help it kind of defrost naturally without doing that heat or change the properties of breast milk. All right, so breastfeeding problems. Again, this is in a different spot, so it's not in the newborn nutrition section, so that's why I put those page numbers there. Sore and cracked nipples. Anybody had a patient on postpartum that had sore or cracked nipples? Yeah. It's a pretty common problem. It is very painful. And I think, again, sometimes, and I'm just being honest here, the nurses don't always do a very good job assessing the breasts and the nipples. It's like they go in, they'll check that fundus, and they'll quickly kind of pull the panties and take a peek. But when it comes to the breasts, again, I think there's this, this thing about breasts in Louisville and Jefferson County. I think it's really important. Do you assess the breasts of a non-breastfeeding mother? Absolutely. Now, she's not going to have sore and cracked nipples because she's not bringing the baby up to the nipple, but we're going to talk about things that she can do to help suppress milk production. So breastfeeding moms that have sore and cracked nipples, actually they might even bleed. That's how bad it can get. And they'll cry. It is so painful, and they'll just sob, and and you take the baby off the breast, and you're like, oh my gosh, I can't even imagine that you're putting the baby there. So if the mom is complaining about sore and cracked nipples, the number one thing that you can do to help with that is change the position of the baby. And it's because the way the baby's sucking it, the friction point on the nipple is the same exact location. So changing the position. So that's why we really, when moms are starting to breastfeed, it's better to get them in the habit of changing positions of the baby frequently. It's another healthcare thing, just like pressure injuries and all kinds of UTIs, all kinds of prevention is way better than once you have it. It's really difficult once you have it. With sore and cracked nipples, I've seen some lactation consultants where, depending on if it's one breast or 2 breasts, they do actually will have the patient kind of stop breastfeeding temporarily to try and let that sore and cracked nipple heal just a little bit. But some of it has to do with moisture. She's nursing a lot, the baby doesn't have a good latch. So that's another reason why when mom's nurse, after she's done taking the baby off, you wanna use your finger to release the latch. And then use a little bit of the breast milk, and that's an emollient. It helps, again, keep the skin intact. You let the flaps down on the nursing bra and just let the nipples air dry after a feed. So again, I think position change is critical, but I think the other thing is using some breast milk after a feeding and then letting the nipples air dry. That's what I've seen in my experience works best for sore and cracked nipples. In some cases, sometimes I've seen some physicians, they actually had the patient like put antibiotic ointment because they were concerned about infection. Sore and cracked nipples put you at really high risk for mastitis, and we'll talk about that tomorrow when we do postpartum at risk. Engorgement is also very common. So these are very common things that occur in breastfeeding moms, and I think it's important to early recognition by the nurse, teaching by the nurse to the patient about how to prevent them, and then what to do when it does happen. So with engorgement, the breasts are very full, they're very painful, swollen, and the breast is so tight, the baby cannot latch on and can get the milk out, okay? So some things with engorgement, the reason we see that is missed feedings. So you've got a really tired mom, you've got a really sleepy baby, and mom went 8 hours and didn't feed the baby. So now the breasts are like gigantic, over full balloons, baby's crying, it's kind of a miserable combination. Sometimes it happens to moms who are trying to do the breast bottle feed combination. So some well-meaning parents, I'm gonna breastfeed during the day, but I'm gonna bottle feed at night because I wanna sleep, and I don't want the baby to get up in the night and cry and wake up the whole household, because not only am I tired, but my partner's tired and my other 2 kids are tired. So I'm just gonna give the baby a bottle at 9 o'clock at night, and we're gonna, oh, and let's put a little rice cereal in there. So that happens a lot around here, and it's a big no-no. It's a big no-no. If you're gonna supplement, you only supplement with as little as possible, and even if you're supplementing, that baby should still eat every 4 hours, okay? That baby should not be sleeping through the night first week of life. I know you're tired, but baby will still wake up, okay? So engorgement, with engorgement, sometimes what we'll need to do is express a little bit of that fore milk, remember that alleviates thirst, and to soften the breast so that the baby can latch on. We do not pump, because when you pump, it's gonna increase the supply. You already have a supply problem, okay? So in other words, you express just a little bit of that fore milk to make the breast softer, but usually if the baby nurses more, that actually takes care of engorgement. Do not have the baby nurse and then, oh, I still feel like the breasts are really full, I'm gonna pump afterwards. That's just a signal to your body to make more milk. You're gonna have even worse engorgement the next time. Does that make sense? That's a really important concept, because I think a lot of people are like, oh, well, I'm just making all this extra milk, I don't want it to go to waste, so I'm gonna pump. That could actually make this worse. Okay. All right. Don't memorize all the teeny tiny pieces of this. Are you using this at your facilities? I don't think Norton's uses it. I thought Baptist did. Again, every hospital is a little bit different. This is a evidence-based practice tool to evaluate breastfeeding and give it a quantitative measure. Notice it has 5 criteria. It's very similar to APGAR. I would never give you a scenario and say, what's the latch score? But let's just look at it. If the latch score, latch is an acronym, it stands for latch, audible swallowing, type of nipple, and type of nipple is on mom, not the baby, comfort, and then hold. And so if you have a high latch score, all of these things are in place. The baby latches onto the breast, the tongue is down, the lips are flanged, there's rhythmic sucking, you hear the baby swallowing, the nipples are everted. Everted is a good thing. The breasts are soft and non-tender, and that mom does not need any assistance from the staff. Versus down here, baby's sleepy, not latching on, you don't hear any swallowing, inverted nipples. So has anyone mentioned breast shields or talked about breast shields at all on Mother Baby? Yeah, okay. Again, not something I'm super familiar with. I think we have to be cautious about it. Usually there's some problem with the nipple, why we use a breast shield. And then usually if we have somebody who needs that, we really want to get lactation consultant involved, because the expert experts can really work with that patient. I don't think it's necessarily something the patient's gonna use long-term. It's just to kind of get that latch established, to help in that transition from colostrum to transitional milk. Engorged, cracked, bleeding nipple bruises. You get bruises on your, yes, some babies, they really clamp down. The other thing is if you're on any type of anticoagulant therapy, you can get bruises, and then if you have bleeding nipples, they bleed a lot. And that could be really scary for a mom if they're on anticoagulant therapy.
So they can be inverted for like a temporary times, not necessarily like.
So
sustained.
ideally, somebody has been assessing them throughout the pregnancy, because they can actually work on trying to evert them more through the pregnancy. Unfortunately, when you do that, sometimes that can cause contractions in preterm labor. So we try to make them more everted if we can. The shield will help with that. Sometimes we're not very successful with that. But yes, it's one of those things, the more time you have to try and evert them, the better. Some of it has to do with the breast tissue. Some women have very large pendulous breasts, so it's really hard. You know, you can say you want that areola in the baby's mouth, and the areola is so large in the baby's mouth, they can't get it all in. So they're not compressing the ducts of the breast to be able to empty it. So that's another issue that makes breastfeeding really challenging. So again, with latch, it's just a mechanism for us to kind of evaluate breastfeeding. A higher score is a good thing, a lower score is a bad thing. And then remember in lab, we talked about different types of positioning. So we did the football hold and cradle hold and sideline. We like sideline, particularly for moms who've had C-sections, so the baby's not lying on the incision. But again, we really want to mix up positions. The other thing is some babies have a favorite breast. And actually, it's not really a favorite breast, but it's where breastfeeding is most comfortable for mom. And so mom has a really good letdown reflex, so it's like, wow, the baby nurses really well on the left side, but the right side doesn't seem to be working. And so you could have one engorged breast that the baby's not nursing very well from. And so again, positioning is really kind of the best thing there. What I find when I work with moms, it's lots of pillows, supporting the arms, and they have to really bring the baby close. And then usually what I will do is I'll ask permission, I'll put gloves on, and I'll say, if you don't mind, I'm gonna touch your breast while you put the baby on. And then a lot of times you're actually just making sure you're providing room around the baby's nose, because if you have somebody with a really large breast, and they have that breast tissue up around the baby, so the baby puts the mouth on, but they can't breathe, so they won't suck. So I kind of encourage moms, take your fingers and just depress that breast tissue a little bit so that the baby can breathe through his nose while they're on the breast. And I think, again, a lot of women, they're like, you know, but once you kind of show them that, they're comfortable with it, but it's kind of teaching them. So we talk about things like scissor hold, right, and using your thumb and different things. So that's something that we really need to observe the breastfeeding. And I think that's another thing. People go off forward, oh yeah, the baby's feeding fine. How long was the baby on? Oh, about 15 minutes, because they know that's what you want to hear as a nurse. And you really need to see them nursing to see if it's really working as great as they say it is. So on that note, we're at a good spot here, so let's take a